Barrow's Neurologic in Phoenix to join us and do Journal Club. Thank you very much, Dr. Uribe, and welcome aboard.
Okay, thank you, Seattle Science Foundation, Dr. Segler, Chapman, all the Texas Back Institute as well. Today, we are honored to perform the Journal Club, and I have my colleague, Dr. Jay Turner, that it will be moderating with me. And just to make it more productive, I think is a good time to get started. So our first paper of the day, it will be presented by Dr. Coffey, which is one of our fellows at the institution. So Dr. Coffey, if you want to go ahead, and then we go from there.
Okay, thank you very much, Dr. Uribe. Good morning, everyone. It's a pleasure to do this. So I'll just take it from the top. So we have a couple of papers here, but we thought we'd start with one that's very simple, but very important as well. And the paper is a paper from Dr. Uribe's group that's titled Analysis of Cost in 30 Days Outcomes in Single Level Transforaminal Lumbar Interbody Fusion and Less Invasive Standalone Lateral Transpsoas Interbody Fusion. So this paper tries to compare outcomes and cost. And as you know, in the healthcare climate, two things are very important for all healthcare professionals, particularly spine surgeons as well, which is outcomes and cost. And the emphasis is always to try to create value for patients. So value is defined by this formula here on the screen, which is outcome as the numerator and a cost as the denominator. So to improve outcomes, to really create value for a patient, you have to make sure your procedure is not only improving their outcomes, but also decreasing cost. And this is how you can maximize it. So in this paper, they try to compare XLIF versus a TLIF. And this diagram demonstrates all the different approaches where you can actually approach the spine. I don't have to go through any of them, but the bottom line is in a spine pathology, you often have options. And should you be thinking about creating value when you are trying to decide which option you're going to take? So let's just dive right into the paper. So the methods are here. So it's a retrospective review of just 20 patients, 10 with who underwent MIS TLIF and 10 underwent standalone XLIF. And then they looked at the fixed and variable cost as well as the total cost. And then in terms of outcomes, they recorded intraoperative time, EBL, intraoperative complications, as well as several postoperative parameters, including 30-day outcomes, to what extent the patients returned to the emergency department, how much medication they required, and readmission rates, et cetera. So the first table in the paper really looks at the demographics of the patients that were involved in the study. Overall, in age, BMI, whether they had diabetes, gender, use of tobacco, et cetera, were all well matched. But in two areas, which is whether they had obesity or the extent of comorbidities they had, the lateral interbody fusion population had higher percentages of obesity, and they had more comorbidities than the usual MIS TLIF. This highlights the first data set. So this is the operative data. So when they looked at operating room time, the lateral interbody fusion group had a better time in the OR. So almost half of what the MIS TLIF group did. And this was statistically significant. And then they looked at EBL as well. So it's 14 over, well above 200 in a TLIF group, also significant. The length of stay was shorter in the lateral group compared to the TLIF group, but based on the size of the population they analyzed, this was not statistically significant. And then they looked at intraoperative complications as well. Again, not significantly different, but two of the patients in the MIS TLIF group had thoracotomies and CSF lead. Okay, so Then they went in to look at the cost data. So they looked at fixed costs and variable costs. And overall, the lateral interbody fusion group had about $8,000 of saving. And this data looked at only inpatient costs, so it did not really consider rehab or what happened when the patient actually left the hospital. But if you dig deeper, you see that a lot of the costs came from the variable costs. So the fixed cost was a little higher in the MIST lift group, but it was the variable cost, which relates to implants, amount of time you spend in the OR, how long the patients are in the hospital, what kind of services they need while they're in the hospital. And this is where you get a lot of the price difference between the two approaches. So overall, the lateral interbody fusion operation, when you consider all the inpatient costs, it was about $22,195 compared to the MIST lift, which was $29,951. And this was statistically significant as well. And so when you dig deeper, so you can have variations as you expect. And when you dig deeper, you can think, okay, is there a way I can actually do an MIST lift that will actually be cheaper than just doing a standalone X lift? And even if you look at the range of the cost, okay, so down at the bottom of the table, you can see that the lateral interbody fusion can be done in some patients as cheap as about $14,000. But the cheapest you can get an MIST lift done was about $18,000. So overall, it was a more expensive operation when you think about the variable cost. And the total cost was still pretty high in the MIST lift group. And then this kind of highlights also the different ranges of BMI and so forth. And you can see that the lateral interbody patients were actually larger and had higher obesity, and they had higher comorbidities as well. And yet they had very similar outcomes when you look at the amount of time they came to the emergency department for pain medication, readmission rates, when you look at complications such as infection and so forth. They had very similar outcomes, but the cost was different by about $8,000. So the conclusion of this paper then is that the single level standalone lateral interbody fusion was more cost effective than the MIST lift. They had very similar 30-day outcomes in the groups, but obviously the paper had a number of limitations. So first, it was a very small sample size. So there were 20 patients involved in the study, and it was all from a single institution. So this kind of creates statistics problems. So you have difficulty comparing groups. For instance, we know that in our hospital, when you do a standalone X lift, patients go home the same day. And usually in MIST lift, they go home either the following day or the day after. And the pain level is higher and so forth. But when you do the statistics, this doesn't pan out in the data. It says there is no difference. Also, when you look at the granularity of the cost data that we have, you can't really identify the cost driver. Is it because the implant cost for the lateral interbody fusions is actually higher than the one of MIST lift, or is this something else? What are the cost drivers? Because having clarity on this allows one to actually start thinking about smart ways to be more efficient, to decrease costs and make a difference. Another limitation in the paper is they had no indirect cost analysis. So a lot of these patients had, they may have gone to rehab or they may have lost work. And that is also cost that needs to be considered and reviewed carefully to see if one procedure is better than the other. The other issue was that they had only 30-day follow-up outcomes reported. So there was really no long-term. And the tradition is to do 90 days, but it's unclear whether one group was better than the other. And finally, the indications were variable. These were not homogeneous indications for the operations. And so it's unclear whether some patients would have benefited from one approach versus the other. Nonetheless, this paper raises a number of very important questions. For spine surgeons, should we really worry about cost? And how important is that? If you're not in private practice, should you worry about cost at all? And should we try to think about ways to create value for patients when deciding what approach to do an operation, or should we just focus on what we are comfortable with and do that operation? And, cost can be related to things that you don't see a dollar sign to immediately. It could be like OR time, how long the patient stays in the hospital. And then also, should we worry about what the patients really care about? What are the patient-reported outcomes? And then how does this paper elevate the need for ambulatory spine surgery as the first go-to place to do a lot of these operations instead of inpatient sites? So that's all I have, and so we can go ahead and start questions now. Thank you very much.
Thanks very much, Dr. Coffey. Actually, we choose these manuscripts because always socioeconomics is important, and unfortunately, we are nowadays driven by that. And there was always this conception that when you do these lateral cases, they comes with a really big, expensive toll. And which is interesting is that, for example, for single levels interbody fusions, when you go lateral, you not necessarily need to use hardware. I mean, we're talking about screws. Every time you do a single level transforaminal T-leaf, you have to have screws. I haven't seen standalone T-leaves. So that's why we wanted to see what was the impact of the economics on this. But I want to leave it to our senior and good discussants to talk about what you guys is your take on this, and I'll go from there. We have probably 2 more minutes to discuss this paper. Any of you guys want to say something?
This is Jens.
Yeah, I'm not, oh, go ahead. I'm sorry, Jens.
No. What was the main cost driver then? Was it OR time? Was it implant cost? If I understand the paper right, the MIS patients were in the OR for 4.5 hours. So that's a long time. So what drove the costs in your analysis mainly? Was it truly implants or other factors?
Coffee.
Right. So a lot of the cost actually comes from things that you don't see up front. So you're charged for the amount of time you spend in the OR. Overall, the implant cost is actually higher in MIS T-lift because you have the inner body, you have screws, you have rods. And then also those patients require more services while they're in the hospital. So a lot of these things that you don't predict before starting the operation actually plays a role in how expensive they become.
Thank you.
I think you brought up a limitation of the study, the lack of long-term follow-up, because a huge driver of cost. I mean, maybe this paper is, better entitled, short-term costs of comparing 2 procedures, but a huge driver of cost is, does the operation work? If you've got a 10% failure rate in one operation and a 30% failure rate requiring reoperation in another, that's where the real costs come in. And also you mentioned the need for rehab, but that's another issue as well. But so I'm not sure how much we learned as a takeaway from the paper.
Yeah, I mean, this is really taking an operation out of context. As Scott said, you really need, a longer term follow-up and the whole continuum, cost of the continuum of care. So there's not a lot to take away other than the fact, the obvious, that if you do a standalone, T-lift or X-lift, that it's going to be cheaper than screws and an implant.
Less hardware and shorter operative time equals less cost.
One of the things that I see missing in this paper as well is the levels. I don't know. I didn't see in the paper where they stratified the T-lift and the lateral lumbar according to the levels. If you're doing a T-lift at L5S1, that's going to be very different than an X-lift standalone at L3-4. So I don't know that you're comparing the same things, and it doesn't seem to be brought out in that paper.
Juan, it's Neil. I don't know if you can hear me.
Yes, sir.
I gotta agree with all the last 3 comments. You know very well that standalone laterals have a failure rate, anywhere between 7 to 10%. And it is rather unfair, but a lot of them fail. They'll end up with revision. They get the screws in the end. Of course, the T-lift, you can't do standalone. You got to put screws in the T-lift. Yeah. But you're right. The T-lift, there's 220 centimeter cube of blood loss on an average of the T-lift. Kind of odd. Also 4.5 hours. So you got to agree, is the expertise on the two actually the same? Maybe there's some surgeon who's very good on the lateral and probably not that good on the TLIF. So I think you got to look at a lot of those things too.
No, there's a lot of variables. And as I told you,
Yeah.
the main reason we did it is to trying to demystify this, that they say that lateral surgery is outrageous expensive, you know,
Right.
and I was like, listen,
Right.
if you do a standalone single level compared to single level TLIF, it's not as expensive as you think. You know, obviously it has a million flaws. It's just because if we don't put some socioeconomics on upfront on this, you know, we keep this, you know.
But maybe you could follow this up, you know, looking at it a year out.
And you know,
Let's start
90 days, 90-day readmissions,
year
a lot
out.
of factors that are very hard. I mean, I totally agree with you guys. But I think for the sake of time, we should continue with the second one. Jay, you want to introduce the next paper?
Yes, thank you. Yeah, so thanks again to Rod and Jens and the whole team for the invitation to participate. I'd like to introduce Dr. Bernardo de Andrada, who's going to be presenting another paper in biomechanics. He's spent a couple years with us as a research fellow and is now as a clinical fellow with us this year. So Bernardo, you're up.
Okay, hi, good morning. I'm Bernardo Andrada. I'm going to speak about the biomechanics of anterior column realignment, ACR. No personal disclosures. So this is the paper we are talking about. It's biomechanic cadaveric study we're performing here at our institution. Was published on the Spine Journal. I'm sharing the QR code for those who would like to check the paper. So basically, ACR, anterior column realignment, is a lateral technique where we use transpsoas corridors to promote the anterior longitudinal ligament release and the implantation of a hyperlordotic cage or interbody in order to promote the anterior column lengthening and that way restore the lumbar lordosis via MIS approach. In order to maximize the potential for achieve lordosis, usually posterior osteotomies are performed. And also the anterior interbody comes with plates integrated where you can choose to fixate with only one screw into only one vertebral body, or you can choose to fixate into one screw, two screws, one vertebral body above, another one the vertebral body below. And there is a debate whether or not if you fixate with two screws, you could limitate the potential for lordosis correction. Also, the extension of the osteotomy, it's another factor that potentially could impact the lordosis achievement. Well, since ACR usually comes with long posterior constructs, there is a need for sharp rod contour. The rods are usually vulnerable. The same happens on other high stress sites like PSO or lumbosacral junction. And there was no cadaveric study looking exactly to that matter previously. So we performed that study in order to optimize the constructs and try to increase the longevity. So Januszewski in 2017 did this computational analysis saying that ACR has similar stability than PSO with 4 rods. So basically the objectives here are answer that questions. Should we use 1 or 2 screws anteriorly on ACR? Should we use 2 or 4 rods posteriorly? So also the degree of the osteotomy can impact the potential for lordosis achievement. How about the choice for anterior fixation, 1 or 2 screws? Does that impact the lordosis correction? So we performed the strain study. Strain is an indirect way to infer the stress. It's basically the change of the length of the material surface after application of a force compared to the initial length. So we divided our study in 2 groups, in 2 phases. The first is the radiographic, the second is the biomechanics phase. We studied basically 7 cadaveric specimens where we performed ACR at L3, L4, and we tested with 1 and 2 screws anteriorly and 2 and 4 rods posteriorly randomized, and we look at the range of motion and the rod strain. This is the radiographic phase. We performed sequential osteotomy. Since no osteotomy, grade 1 and grade 2, 1 or 2 screws anteriorly and we measured the compressive force used to achieve the lordosis using strain gauges on the compressive tube. And during the biomechanical phase, we tested the specimens in our 6 degree of freedom robotic test frame using pure moment loads, and we tracked the range of motion and the strain. This is our facility. This is our robotic test frame for biomechanical tests on the right. It's just a couple pictures of the specimens just for illustrate the osteotomies, different grades of the osteotomies performing. You can see on the X-ray 1 versus 2 screws and grade 1, grade 2 osteotomies, 1 screw at the top and 2 screws at the bottom. So this is the results. So basically there was no statistical significance difference between 1 versus 2 screws, no matter the degree of the grade of osteotomy. And there is also no difference in compressive force when you compare 1 versus 2 screws. These are the graphs where you can see the same thing that I just said right now. However, there was a difference between the grades, the osteotomy grades. When you perform grade 2 osteotomy, that requires less compressive force to achieve the lordosis. So significant less compressive force was required when grade 2 osteotomy was performed. So maximal segmental lordosis can be achieved using only 1 or 2 screws if you perform grade 2 osteotomy. Osteotomy is really what impacts the potential for correction and not the choice for 1 versus 2 screws. This is our range of motion graph. Basically, what I would like to show here is, well, once you release the ALL, the motion really increases. It makes the constructs really unstable. So releasing the ALL has a high destabilizing effect. The most unstable condition was only 1 screw anterior with 2 rods posterior. This was the last stable condition. And the other conditions, there was no significant difference. So basically ACR, 1 screw anterior, 2 rods posterior, less stable. No difference between 1 or 2 screw anterior when you go 4 rods, but if you go only 2 rods, 1 screw is less stable than 2 screws. This is our rod strain graph. It shows here that what's really important for protect your main rod for increasing strain is using 4 rods. Using 2 screws anterior did not impact really the posterior rod strain. So basically summarizing the rod strain results, 4 rods is exactly what helps to reduce a rod strain using 1 or 2 screws. No significant difference in rod strain between 1 or 2 screws when you go 4 rods, and addition on the second screws anterior with 2 rods did not significantly reduce the rod strain. This is just an illustration that we perform here at our institution to show 1 screw and 2 rods makes the rods has like larger strain. So here there is some points for discuss. First is emphasize the stabilizing effect of the ALL release. The need for contour the rod and for the release the ALL puts the rods vulnerable. When you choose the ACR, especially when you do at the lordotic apex, the rods are usually what bears the weight, the posterior column, which bears the weight of the body, while the ALL has more the function of protect from translation or from shear force. 2 screws usually requires a broader psoas opening, a prolonged operation time. 4 rods in an MIS surgery may be a surgical challenge. And when you're performing higher levels with lower risk of plexus injury, may we favor to use 2 screws when you can. And this is not part of the paper, but this was all part of the big study. We also had some side questions. So ACR and PSO, they we did a comparison. It was not published yet, but they basically has a similar stability with benefit from using 4 rods in terms of rod strain. And this is also another question. There's a positive correlation between lordosis versus strain. It means more lordotic the construct, the tendency is you have more strain on the posterior rods. That study is not without limitation. The strain gauges, they usually only look to the strain in a specific spot of the rod. We are envisioning new technologies that could potentially look at the strain throughout the construct. So the conclusions are ACR is results in instability in high strain. Use of 2 screws improves instability, but not improve the rod strain. And the use of 2 screws does not impact or does not impair the maximal achievable lordosis. And the use of posterior extra rods improves stability and decreases the posterior rod strain. And there is no benefit combining both 2 screws for rods. This is again a QR code for those who would like to check the paper. And that's it. Thank you. And questions?
Great, thanks, Bernardo. So yeah, so the impetus for this study was really to, ACR is a relatively new technique. It's powerful in terms of its realignment potential, but the clinical data on instrumentation outcomes is not really there yet. It's still a relatively new technique, but we know from the 3-column osteotomy literature that failure rates are very high, and anyone that's done an ACR can see how destabilizing it is in surgery. And when it was introduced, the presumption was the too much anterior instrumentation would limit your corrective potential. And so we were really interested in, from a biomechanic perspective, what provides the best biomechanical stability, and does that compromise the realignment potential, which was really the interest in this project. And so certainly be interested in hearing thoughts from panel and the participants. Open up for questions or comments.
Thank you for bringing this paper to our attention. And again, this is a big deal. For me, the main learning point and the question, especially to our deformity colleagues like Izzy, is it seems that if we truly destabilize the spine and want to restore lordosis, not only do we need a good quality cage that supports the apophyseal ring structures of the vertebra, we also need 4 rods. I mean, that for me is the main learning point, really. I mean, this has been a quantum leap difference that's just over the last 2 or 3 years has just become almost a new standard of care. If you do a true osteotomy, forget the old biologic fusion techniques, you probably need to consider a multi-rod construct. So your comments would be appreciated. Thank you.
So Jens, I'm gonna take a little different tact on that, and I think we are falling into this trap again of thinking that the answer is heavy metal, more rods, more screws, more cages, more. The answer is really going to be understanding the balance and the biomechanics of the spine and optimizing the fusion rate, because it's still always a race between fusion and hardware failure. And we can put 4 rods in, we can put 6 rods in, but if the spine doesn't fuse, all we're doing is kicking that can down the road, and you're going to have a different type of hardware failure at 6 years instead of 4 years. So I think we've got to be looking at all of these things. Quite frankly, I'm afraid of this 4-rod philosophy that's coming out, because in 2 years we're going to start saying 6 rods, and I think that's the wrong way to think about these things.
Yeah, that's great. Thanks very much. I think we should move over the next paper. So this one actually, I like this paper a lot. This paper actually came as a response to multiple difficulties that we have when you are the deformity surgeon. You go to your cases, anesthesia, they don't have a real standardized way to do a neuromonitor anesthesia. So Dr. Walker put together this paper, which I think is really helpful in terms of streamline anesthesia and neuromonitoring. So Dr. Walker is one of our chief residents. Welcome, and don't forget to stay within the 10 minutes so we have good 5 minutes of discussion.
Yes, thank you. I'm one of the chief residents here. Thank you, Dr. Uribe. Thank you, Seattle Science Foundation, for having me. As Dr. Uribe just mentioned, we're going to be discussing this paper here, which we published last year in Spine as part of our journal club today. You could see multiple points of input across the world and some really great contribution to help this study get going. Anyone who performs complex spine surgery and deformity surgery understands the importance of assessing neural integrity intraoperatively with our neurophysiology. And essentially, there's good evidence to date, level 11 evidence specifically, that suggests that multimodal monitoring with SSEPs and MEPs combined provides the best means for intraoperatively assessing the spinal cord's integrity. However, we know that MEPs are superior. They provide instantaneous feedback to the surgeons, and it's incredibly important as a tool in our arsenal to be using good, high-quality MEPs during cases. The problem is that MEPs are severely affected by the patient's hemodynamic status as well as the anesthetic regimen. And so the crux of the problem is that our most important tool for intraoperatively assessing safety is being performed on the other side of the drape. And so it's our anesthesia colleagues who have control over our most important tool, which is not good for surgeons who like to be in control. And so what we sought out to do was to identify a set of guidelines that could be used to help anesthesiologists and their spine surgery team to have a set of guidelines for the anesthetic regimen that could be helpful for producing high quality MEPs during cases. We know that there's a huge amount of heterogeneity from anesthesiologists. In particular, this occurs when you have anesthesiologists in places who do not routinely perform these cases. And so our goal was to use a modified Delphi method for achieving consensus on a set of guideline statements that could be helpful for surgeons and their teams using MEPs. The first task was to identify our panel of spinal deformity experts. So we had an international team of people who routinely perform these complex procedures, and we had them work with their anesthesiology teams, their head of anesthesiology who routinely performs these cases with them. We collected their protocols to see what people are doing, identify points of variability and consistency, and then use the Delphi method to have this iterative process of achieving kind of the sense of agreement on things that we could recommend. And so we went through a series of 2 rounds of surveys after the initial protocols were reviewed, and then we went through a final set of statements which were agreed upon by all members of the team. This is our final set of guideline statements that we had. We used the cutoff arbitrarily, and this has been used in other studies, of 75% to indicate consensus, whereas we said if more than half of the experts agreed upon it, we had agreement. And so you can see the statements here. I'm going to go through them briefly. The first has to do with our pre-induction. There's a set of medications that are frequently given as what we call preemptive analgesia, dexamethasone, acetaminophen, pregabalin. These are routinely given and are felt to be safe as part of any sort of anesthetic regimen without compromising MEPs. All of our panel agreed upon that. Another common thing that we saw in protocols is that a lot of the anesthesia teams will give Midazolam prior to induction to help ease patients' anxiety, and we know that benzodiazepines, even a single dose, can significantly reduce our MEP signals. However, it was felt that these could be given as a single dose preemptively specifically with midazolam, without having any significant intraoperative effects on MMPs, but benzodiazepine should not be given routinely through the case. Neuromuscular blockade, this is kind of a seemingly obvious point, but should be mentioned. If you block the muscle action potentials, obviously you're not going to get motor evoked potentials. And so if they are used, reversible agents such as rocuronium, which can be reversed with sugamidex immediately, is the agent of choice. And otherwise, you can get a problem with your motor evoked potentials just from this alone. Often we see in the OR, anesthesiologists will say that their neuromuscular blockage should have worn off, but the reality is it's still lingering, and it has a tremendous effect on your motor evoked potentials, as you'd expect. So this should be reversed prior to assuming your baseline signals. The most contested part, I believe, especially amongst anesthesiologists, refers to the concept of whether you should use total intravenous anesthesia or whether there can be a mixed inhalational and opioid-driven regimen. I think that the reason we only agreed here, reached agreement here rather than complete consensus, is there's a number of old literature papers that suggest that if you have a 0.3 or a 0.5 concentration of your mean alveolar concentration, or MAC, that you can still run motors successfully. But this is a very clear dose-dependent relationship, and in patients who have pre-existing myelopathy and spinal cord compression, which is often your most important group, these can be compromised at the first place. And so having any gas on board can be limiting in your ability to get real accurate MEPs. And so we stress that if you're going to be doing that, in this case, is the highest quality motor evoked potentials is used with a TIVA regimen. As such, propofol can be used safely in the vast majority of patients, but it too has a high dose-dependent relationship. We tried to establish a cutoff by which we could devise to say, well, what's our safe dose that we can give here? We found that about 50% agreed that it should be less than 100, and 75% agreed that it should be less than 150. So we used that as our, probably that's the highest dose based on our consensus that should be given. And then as you can tailor to your awareness and wakefulness during surgery to limit the dose of the propofol, because this too can impact your signals. Overall, we have looked at multiple other adjunctive medications such as ketamine, lidocaine, and Precedex. These can be used as part of a TIVA regimen to help spread apart the amounts of the medications that you need to use, so you don't need to use any of the high doses of these. Ketamine has its own limitations, and so does lidocaine in terms of some of the side effect profiles. And Dex at high doses too can have suppressive effects on MAPs and should be used carefully. There was no consensus on the exact opioid that should be given, although there was consensus that bolusing of opioids should be avoided, and that methadone can be used safely in these patients. When we asked our teams what if they did not achieve MEP signals, would be the most likely cause, the highest rated answer was that the inhalational anesthetic would be the most likely cause, and that if there's any running, this should be stopped and converted to complete TIVA if it wasn't already being used. And then obviously assessment of spinal cord blood flow by looking at the hemodynamic status, the patient's body temperature. And there's numerous studies out there published about how to go through a patient checklist to address loss of signals intraoperatively. So in conclusion, we felt that we were able to devise a set of guidelines that we felt may be helpful to anesthesia and spine surgery teams, and help guide them for motor evoked potential cases when performing complex spinal surgery and deformity procedures. Thank you.
Thank you, Corey. May I ask a question? So what I didn't
Please.
quite understand, thank you for bringing this to our attention. This is, again, a big deal and fits nicely to last Tuesday's excellent UPenn discussion of complex deformity surgeries and neuromonitoring. So during dissection of larger open deformity cases, we frequently like to have kind of just muscle relaxation to help us with our dissection. Do I understand from your consensus assessment that this is something that's acceptable, or is that just creating too much of a pollutant to our monitoring needs to be a safe and acceptable practice?
No, I think that the point of it is that if you're going to use neuromuscular blockade, that it's just that it's reversible. We too use that here, particularly for our open spinal deformity procedures, where the muscle relaxant provides a great benefit during dissection. I think it helps lower blood loss. And there is even some institutions that suggest that if you use a very, very small dose of a neuromuscular blockade, you can actually inhibit some of the background noise that's achieved from having the motor evoked potentials, like the baseline kind of low-level noise that's seen with the recordings. I think in general that's a very complex high-level maneuver, maybe that should only be performed by really experienced anesthesiologists and people who do that frequently. I can imagine that if we lost any sort of signal, that'd be the first thing you'd be worried about. So I think that your ability to reverse is the most important key. And I think if you have a case where it's not just a pure scoliosis, but you have ongoing cord compression where you need to be monitoring from positioning to the end of the case, and your sphincter never really releases in those cases, I think that any neuromuscular blockade may be preventative in those situations.
Which brings me to one other question that is so pertinent. What I would have loved to see in this assessment is how many centers actually have dedicated neuroanesthesia teams versus the usual kind of a parade of different colleagues who are just kind of doing their time on a spine service. So that's truly something that we always struggle with, and we have a very high volume, highly dedicated anesthesia group also, but even there we have inconsistencies.
Yeah, and that's the main reason of this, you know, specifically when let's say you're a new surgeon going to a new practice, trying to start your deformity practice, and you're hitting a wall when there is no standardization what to use when you're monitoring. So, and I say the biggest conclusions is TIVA, you know, in total intravenous anesthesia is the best friend of the monitoring. Every time you add gases, you start losing things. Definitely muscle relaxants has no room in this game. So I'm gonna pass to Dr. Jay Turner so he can introduce our next speaker. Thanks very much, Dr. Walker. Jay.
Thank you.
Thank you, Corey. Next up, we have Dr. Jake Godzik, one of our chief residents who's going to be discussing a recent paper on prone lateral surgery. Welcome, Jake.
Good morning. Okay, good morning. My name is Jake Godzik. I'm one of the residents at Barrow Neurological Institute, and I'm going to be talking about single position prone lateral approaches to the lumbar spine. Specifically, we'll be reviewing this recent publication in Neurosurgical Focus entitled Single Position Prone Lateral Approach, Cadaveric Feasibility Study and Early Clinical Experience. So as a brief introduction, the trans-psoas approach is typically performed in the lateral position, lateral decubitus position on a table that facilitates opening of the space between the rib cage and the iliac spine, tensing the soft tissues, and the dissection is performed directly vertically towards the floor. However, typically when we perform trans-psoas fusion, we also want to perform circumferential fusion with percutaneous or pedicle screws posteriorly. And this requires a repositioning between steps, which is a little burdensome for the OR and time consuming. So there's been a movement towards single position surgery where both aspects of the surgery are performed in one position. And it has been described more typically in the lateral position. So the patient is lateral decubitus, the transpsoas interbody is placed, and then percutaneous screws are placed in the lateral position. And this has some difficulty with it, and surgeons have been struggling and describing this for a while. However, there's been a discussion and a movement towards performing the entire set of procedures in the prone position. So this is a recent article out of Italy describing an experience with 7 patients who underwent both lateral transpsoas and percutaneous screws in a single position, the prone position. So our objective for this study was to describe our own initial experience by looking at first cadaveric feasibility of this approach, looking at clinical feasibility via a retrospective study design, and with a consecutive case series design. We looked specifically at patient demographics such as age, gender, and BMI, surgical details such as the total duration of the case, retractor time, electrophysiological thresholds, and screw accuracy. And then we looked at radiographic parameters such as lumbar lordosis and coronal cob before and after surgery. We also looked at subjective outcomes such as the ODI and the back pain visual analog scale. In terms of the steps, the patient is positioned prone on a Jackson table with the lateral transpsoas approach being performed as one of the arrow indicates here, and the percutaneous screws being placed posteriorly. There's a bolster placed on the contralateral side of approach because this facilitates tensioning of the soft tissue so that you have, again, retraction of the rib cage and separation from the iliac spine, so to ease the approach, and also creates a little bit of an opportunity to correct the deformity that you may be working on. The skin is then marked in usual fashion with AP and lateral fluoroscopy used to identify the level of interest, and this is demarcated on the skin. The patient is then prepped and draped in usual fashion. The steps of the surgery are very similar to the lateral transpsoas approach when the patient is in lateral decubitus. However, the patient is sitting, and it's a little bit different ergonomics of the surgery. You perform dissection and dilation in the same manner. You perform docking of the retractor using electrophysiological thresholds to identify the location of the lumbar plexus. And then the steps of the discectomy are pretty much identical with placement of the interbody in a seated position. And this is where the bolster comes in really handy because it provides something to resistance of the soft tissue so that the body is not moving when this is being malleted in. So in terms of our clinical experience with this patient population, we had 12 patients undergo an attempted prone lateral approach. One patient, however, was not able to, or we were not able to perform this in the prone position. We had to convert to a lateral decubitus, largely due to the patient's body habitus. It was a larger male who weighed 108 kilo with a BMI of 35 compared to our average BMI of around 26. We did note that there were no intraoperative complications as a result of this procedure. We did not note any significant change in the radiographic parameters of the patient. However, no patient had significant deformity to begin with. We did, however, at 60-day average follow-up, did see improvement that was statistically significant in ODI and in the back pain scores. In terms of the surgical time per level, we noted that there was an average about 15 minutes per level. That was significantly lower at L4-5 and was higher at L2-3. We did notice that the electrophysiological values were very similar to the lateral decubitus position, with the lowest values being observed at L4-5 and higher values as you moved higher at L3-4 and L2-3. We did not note any subsidence at any of these levels on routine imaging post-operatively. We get CTs on everyone, and we did not see any subsidence of these cages. This is just an example of a patient, a 35-year-old, who underwent this operation for a grade 1 spondylolisthesis in the prone position. You can see good apposition of the implants and from end plate to end plate here. And this is just a diagram that illustrates the view for the surgeon. And this is a little bit different than you normally see if the patient's in lateral. The ALL is actually closer to you. So the movement of all your instrumentation and your placement of the implant is significantly different than a lateral position. However, the ergonomics are much more improved, at least in our experience. So based on the results of our study, we conclude that this approach for trans-psoas fusion is feasible in patients. It's both safe and effective. We did not have any complications. And again, anecdotally, we did see a reduction in surgical time. We do, however, feel that further investigation will be needed to look at patient outcomes, to look more closely at the time-saving aspects of the surgery and see if there are any consequences in terms of changing the approach. Based on the results and our thought process is sort of summarized in this table here, where we compare the prone approach, the lateral approach for trans-psoas interbody fusion. And we do find that there's significant advantage in terms of screw placement. We just find that screw placement in the lateral position is in our opinion, not as advantageous. However, we do feel that larger patients, more obese patients, are probably better suited for the lateral approach, mainly because of the distribution of body mass in the Jackson table compared to an AMSCO bed or in the lateral decubitus position. So just general comments about this paper. Obviously, it's limited due to the fact that this is an initial experience. This is a very small cohort as a result. So we're looking at only 12 patients in a very short time period that reflects our thoughts and our experience with this procedure. The follow-up is only 60 days, so we're not really looking at a long-term follow-up. And there was really no quantitative analysis of surgical time, so we can't really demonstrate that there's any benefit in time saving compared to traditional two-position surgery. However, I'm sure that's coming down the pipeline in the long term. So thank you, everyone, for your attention. I'm happy to take questions or comments.
I had a couple of questions for the team there. Juan, Jay, just from a surgeon's perspective, what would you guys prefer, the prone or the lateral? And then the second aspect of that is, in the prone position, if you run into a problem in the retroperitoneal space, what's your bailout? How do you fix that problem?
Yeah.
Okay.
Ed, Juan. Yeah, I think those are all great points. And I think it's important to note that this is very early in the experience, and the way the technique has been designed over the past decade plus has been from a lateral position. So all the equipment, the bed, everything is designed for a true lateral decubitus approach. There are some theoretical advantages that Jake nicely outlined of the advantage of being prone, such as being able to save time on the repositioning, the lordosis you may get from the Jackson table, the ability to directly decompress in a comfortable fashion. My early impression is it is certainly less comfortable doing a prone lateral for the lateral portion if you maintain your trajectory parallel to the floor. So you're basically in a sitting position. It's certainly less comfortable with our current setup. But I think as this evolves, I think we'll see changes in bed positioning and changes that allow for the ergonomics for the surgeon to be more comfortable in the prone position for the lateral approach, while still having the advantages of the prone position for pedicle screws and decompression. So I think time will tell. We certainly need a lot more experience and a lot more research to understand advantages and disadvantages.
Can I ask a question?
Yeah.
Juan, I know that everybody's so fixated on not having to change the position, but I looked at the times in the paper, and we do, and I don't do the XLIF, but we do anterior posterior fusion, and our times are very, very similar. It takes about 5 to 10 minutes to switch over to the table, and as Izzy said, we do our A-lifts in the right, in the proper position if we have a problem, and instead of being in an awkward position, and as Jay said, it's a little awkward doing it from the lateral position. And I just don't understand the fixation that everybody has. They have to, how much time are we really saving? And I don't think you really are.
Yeah, that's a great point, Dr. Geyer. Obviously, we're in the learning curve on making timing, doing the lateral to prone. But what I can tell you is now that I'm crossing more than 20 cases, let's say, for example, single level spondylolisthesis, skin to skin today. For example, I'm probably gonna do one today when I leave now. I expect to do it under 2 hours, skin to skin. If I was doing a 4 or 5, the traditional way that I do it, lateral first and then put the patient prone and put the screws, it will take me always more than 2 hours for sure. So the big advantage to me is, it sounds weird, but it's time. But to me, time is more value. To me, is the most valuable asset that we have. Time is what really we trying to buy all the time, believe it or not, direct or indirectly. And then the second one is, obviously, there is a little indirect gains, which is the lordosis that we get on the prone position is really good. I mean, it's the best anatomical position to get most of the lordosis that the patient can give you naturally. And the third one is with the navigation systems. I mean, because we also comparing to single position lateral, trying to put the screws on lateral position is not simple. And the navigation tends to get away because patients rotate. So in prone position, it's the natural position for the screw placement and for the navigation system. So we exploring, we're trying to learn. We just wanted to put together up front our initial experience, but definitely is feasible. If it's really going to change, the thing is also you have a really good oil machine in your you guys at Texas back, they have an amazing system turning patients. In our hospital, it takes at least 45 minutes to change these positions. We need to time out again. We need to change all the scrub. Once you scrub, you have to wait 7 minutes for start doing. I mean, we have a huge protocol when you switch positions that easily is 45 minutes. So in here, basically, I start closing the patient on the lateral. We already start pretty much making the entry point for the screws. I don't know, it's polemic, but that's why we want to bring it today. Any other comments, guys?
Very quickly, so great thought there, and I like your idea about orientation and single position prone far better than trying to do everything lateral. Talk about very briefly in the last minute or two, neurovascular tension, prone versus lateral. Conceptually, an X-lift kind of makes sense because you can relax the hips, the psoas. Have you looked at the tension of the lumbar and the lumbosacral plexus and the iliacs in a prone position versus a lateral?
Jake, you take that one.
Yeah, that's a really good question, sir. We're actually looking at that right now. We noticed that the psoas actually takes on a much less tense conformation in the prone position, which I think, at least initially, was a little counterintuitive. It does take some getting used to, but we are conducting several studies, both imaging-based, to look at what is the shape of the psoas, does it migrate, is it under greater tension, and what are the implications for patient safety and neurological outcomes. We actually not noticed a significant difference in thigh, sensation in patients after surgery. We haven't seen any change compared to lateral, if anything, a little better. But again, that's only based on, as Dr. Uribe mentioned, our initial patient population, which now I think is about 25 patients. So that's a great question, and we're hoping to answer that in the coming months.
Okay, so I think Dr. Chapman and our Texas Back Institute, Geyer, Ziegler, and Blumenthal, you guys want to make the closure statements like on Jerry Springer shows?
I think I volunteer Dr. Lieberman. He's always the voice of criticism.
Voice of criticism. I support advancing the technology.
You're pro-fusion.
The boundaries, boldly going where no spine surgeon has gone before.
One over the head with a chair. Wait till like Jerry Springer.
And use the technology that we have, but be critical. And what we witnessed today is the critical appraisal of some of these things. It's not, Juan and his team are not coming out and saying, this is the way to do it. They're coming out and saying, this is what we are trying. Here are the parameters we're looking at, and let's see if we can do better with it. Now, we all have concerns. My biggest concern is always what's your bailout going to be? You're in the prone position, you're doing something anteriorly,
really
you hit that left common iliac vein, it's going to be a big struggle. So you have to be prepared for all of that when you're doing it.
Yeah.
So
And
great information, great round. Good job, fellows at the Barrow Institute, and we look forward to more. Have a great weekend, everybody.
Thank you.
Thanks.
so,
Be safe.
thank you guys. Good
Thank you,
job.
everybody.
Thanks for watching. Hit the subscribe button for more medical content.